By the end of this session, students will be able to define family planning and its importance in public health, explain different methods of contraception, including mechanisms, efficacy, and side effects, understand medical eligibility criteria for contraceptive use, counsel patients on contraceptive choices, recognize ethical, cultural, and legal considerations in family planning. WHO defines family planning as a voluntary process that allows individuals and couples to anticipate and attain their desired number of children and determine the spacing and timing of their births. Family planning serves as a vital public health strategy that empowers individuals and couples to make informed decisions about reproduction. Its core purposes include controlling fertility, allowing people to choose if and when to conceive, thereby reducing unintended pregnancies and supporting reproductive autonomy. By enabling proper spacing between births, family planning contributes to healthier outcomes for both mothers and infants, reducing risks associated with closely spaced pregnancies. It also plays a critical role in preventing unintended pregnancies, which helps reduce maternal mortality and the incidence of unsafe abortions, particularly among vulnerable groups such as adolescents and older women. To achieve these goals, family encompasses several key components. Education and awareness initiatives inform individuals about reproductive health, available contraceptive methods, and the benefits of planned pregnancies, while also promoting gender equality and empowering women to make informed choices. Access to a wide range of contraceptive, including barrier, hormonal, intrauterine, permanent, and emergency methods, ensures that individuals can select solutions that suit their needs and circumstances. Additionally, preconception counseling provides guidance on optimizing health before pregnancy, addressing lifestyle factors, medical conditions, and genetics to improve maternal and fetal outcomes. Together, these components form a comprehensive framework for supporting reproductive health and informed family planning decisions. Contraceptive methods are grouped by how they prevent pregnancy and by duration of effect. Barrier methods block sperm entry and are used at the time of intercourse. Hormonal methods prevent ovulation or alter cervical mucus and require regular use or replacement. Intrauterine devices, both copper and hormonal, provide long-acting reversible contraception placed in the uterus. These methods vary in typical effectiveness, user dependency, and side effect profiles, and clinical guidance helps match method choice to individual needs and health conditions. Other categories address permanence, behavior, and needs. Permanent methods such as tubal ligation and vasectomy provide effective, irreversible pregnancy prevention. Natural methods rely on behavior and cycle tracking and have higher failure rates when compared with medical methods. Emergency contraception is used after unprotected intercourse to reduce risk of pregnancy and differs in mechanism and time window of effectiveness. Counseling should explain relative effectiveness, advantages, limitations, and suitability of each category, so individuals can choose the best option for their circumstances. Barrier methods, as the word implies, physically block sperm from reaching the cervix. This method includes the male and female condoms, cervical caps, and diaphragm. A male condom is a thin sheath made of latex, polyurethane, or polyisoprene that is worn on an erect penis before intercourse to physically block sperm from entering the vagina. It protects against pregnancy and most sexually transmitted infections, is inexpensive, widely available, and requires no prescription. Its effectiveness depends on correct and consistent use. It is user-dependent and can break or slip, which may reduce protection and interrupt spontaneity for some users. Typical use failure is approximately 13 to 14%, while if properly used, the failure rate is only about 2 to 3%. A female condom is a pouch inserted into the vagina before sex, held in place by flexible rings at both ends to line the vaginal canal and partially cover the external genitalia. It can be inserted a few hours before intercourse to increase convenience. It gives the receptive partner greater control over contraception, provides protection against many sexually transmitted infections, and requires no prescription. Downsides include higher cost and less widespread availability compared with male condoms, potential reports of noise or awkward fit, and a learning curve for correct insertion and use. With typical real-world use, the failure rate is around 21%, while with correct, consistent use, the failure rate is closer to 5%. An important reminder: using two condoms, often referred to as double bagging, and simultaneously using male and female condoms are a common misconception that it provides extra protection against sexually transmitted infections, STIs, and unintended pregnancies. However, this practice is not recommended because friction between condoms raises the chance of tearing or slippage. A cervical cap is a small, cup-shaped device made of silicone or latex that fits snugly over the cervix to block sperm from entering the uterus. It is usually used with spermicide and must be inserted prior to intercourse, left in place for the recommended time after sex, and removed and cleaned according to the manufacturer's instructions. Because it requires a proper fit to be effective, insertion usually follows a clinical fitting and periodic checks, and users may need practice to place and remove it comfortably. The cap's advantages include being hormone-free, reusable for certain types, and usable ahead of intercourse for greater convenience. Major limitation: need for professional fitting, reduced effectiveness for people who have given birth vaginally, and no protection against sexually transmitted infections. Typical use failure rates vary substantially with parity and user technique, commonly reported in the range of about 14 to 29%. So, counseling should cover correct use, spermicide pairing, and alternative options for those seeking higher effectiveness or STI protection. A diaphragm is a shallow, dome-shaped, flexible cup made of silicone or latex that fits inside the vagina to cover the cervix and physically block sperm from reaching the uterus. It is used with spermicide placed inside the cup and around the rim. Can be inserted up to an hour before intercourse. Must remain in place for at least 6 hours after sex, and is reusable with proper cleaning and storage. A clinician usually fits the device and advises on size and placement, and users need practice to insert and remove it comfortably and to pair it reliably with spermicide for optimal protection. Advantages of the diaphragm include being free, reusable for the life of the device, and usable on demand without systemic effects. Disadvantages include the need for a clinical fitting, user dependence, possible urinary irritation or difficulty with insertion for some people, and no protection against sexually transmitted infections. When used correctly with spermicide, effectiveness estimates vary by source, but commonly cited typical use rates range from about 6% to 13% failure in some user groups and up to 13% failure in broader practice. Many clinical summaries report effectiveness around 87% to 94%, with typical and perfect use figures depending on study populations and parity. Hormonal contraceptives are methods that use synthetic hormones, usually progestin alone or a combination of progestin and estrogen, to prevent pregnancy by suppressing ovulation, thickening cervical mucus, and altering the endometrium. Common forms include combined oral contraceptives, progestin-only pills, injectables, subdermal implants, transdermal patches, vaginal rings, and hormonal intrauterine devices. Combined oral contraceptives are a daily pill containing both estrogen and progestin, taken at the same time each day to prevent ovulation, thicken cervical mucus, and alter the endometrium. Consistent daily use is required for optimal effectiveness. Benefits include high contraceptive efficacy with perfect use, reliable cycle regulation, and non-contraceptive advantages such as reduced menstrual pain and improvement in acne. Drawbacks include the need for strict daily adherence, contraindications for smokers over 35 and for people with certain cardiovascular or thrombotic risk factors, and a small increased risk of venous thromboembolism relative to non-users. Typical use pregnancy rates are around 7%, while perfect use failure is under 1%, so counseling should cover adherence strategies and medical eligibility. Progestin-only pills are a daily oral contraceptive that contains only progestin and works mainly by thickening cervical mucus, altering the endometrium, and in some formulations, suppressing ovulation. They must be taken at the same time each day for maximal effectiveness. They are especially useful when estrogen is contraindicated and are safe during breastfeeding, offering an effective, hormone-based alternative with fewer estrogen-related risks. Drawbacks include the need for strict timing with certain formulations to maintain protection and a higher likelihood of breakthrough or irregular bleeding compared with pills. With typical real-world use, pregnancy rates are higher than perfect use rates, so counseling should emphasize adherence and discuss switching options if timing is difficult or bleeding patterns are unacceptable. Depot-medroxyprogesterone acetate (DMPA) is a progestin-only contraceptive given as an intramuscular or subcutaneous injection by a healthcare provider every 12 to 13 weeks. It prevents pregnancy primarily by suppressing ovulation, thickening cervical mucus, and altering the endometrium, and is useful for people who prefer a method requiring infrequent clinic visits and minimal day-to-day action. While active, DMPA is highly effective at preventing pregnancy and is private and reversible after discontinuation, making it appealing for those who want a long-acting but non-permanent option. Common advantages include low user maintenance between injections and real-world effectiveness during the coverage period. Drawbacks include irregular bleeding patterns, especially in the first months, potential weight changes for some users, and possible reversible decreases in bone mineral density with long-term use that generally recover after stopping. Return to fertility can be delayed for several months after the last injection for some individuals. So counseling should cover timing for pregnancy planning. Typical use pregnancy rates are reported around 4%, while perfect use failure is below 1%. This contraceptive implant is a small, flexible rod placed under the skin of the upper arm by a trained provider that releases progestin continuously to prevent pregnancy by suppressing ovulation, thickening cervical mucus, and altering the endometrium. It provides multi-year, low-maintenance contraception and is reversible upon removal. Its advantages include very high effectiveness with failure rates under 1%, minimal day-to-day user action, rapid return to fertility for most users after removal, and discreet, long-term protection. Drawbacks include common changes in menstrual bleeding patterns, the need for trained insertion and removal, possible local site reactions such as pain or scarring, and rare complications like migration or infection. Some users may experience systemic side effects such as mood or weight changes. The transdermal patch is applied to the skin once weekly, and the vaginal ring is inserted into the vagina and replaced monthly. Both releases combined estrogen and progestin to prevent ovulation, thicken cervical mucus, and alter the endometrium, offering contraceptive effects similar to combined oral contraceptives with less frequent dosing. Advantages include improved adherence compared with daily pills, reliable cycle control, and additional non-contraceptive benefits such as reduced dysmenorrhea and acne for many users. Limitations include the same estrogen-related contraindications as other combined methods, the potential for local skin or vaginal irritation, and reduced effectiveness of the patch in some users with higher body weight. Both methods require timely replacement to maintain protection. Typical use failure is around 7%, while perfect use failure is under 1%. Levonorgestrel intrauterine device is a T-shaped device placed inside the uterus by a trained provider that steadily releases a small amount of progestin to thicken cervical mucus, thin the endometrium, and in some users suppress ovulation. It provides highly effective, long-acting reversible contraception for between 3 and 8 years depending on the specific device. Benefits include very high contraceptive effectiveness with failure rates well below 1%, substantial reduction in menstrual bleeding and dysmenorrhea for many users, and low maintenance after insertion. Drawbacks include irregular spotting or unpredictable bleeding the first few months for some users, possible systemic hormonal side effects in a minority, and the small procedural risks associated with insertion, such as pain, vasovagal reaction, infection, or rare uterine perforation. Counseling should cover expected changes to bleeding patterns, signs of complications, and what to expect at insertion and removal. The copper intrauterine device is a non-hormonal, usually T-shaped, device inserted into the uterus by a trained provider that prevents fertilization through a local inflammatory reaction, toxic to sperm and ova. It provides long-acting reversible contraception for several years and can be used as an effective form of emergency contraception if inserted soon after unprotected intercourse. Its advantages include very high effectiveness, lack of systemic hormones, long duration of action, and minimal day-to-day user responsibility once placed. Common drawbacks are heavier and sometimes longer menstrual bleeding and increased cramping, particularly in the first phase after insertion, and small procedural risks, such as pain during insertion, infection, expulsion, or rare uterine perforation. Counseling should cover expected changes to bleeding and pain management options, as well as warning signs that require medical review. Typical annual failure rates are low, commonly cited at around 0.6% per year. Permanent methods of contraception include male sterilization, vasectomy, and female sterilization, tubal ligation. A vasectomy is a minor surgical procedure that interrupts the vas deferens to prevent sperm from entering the ejaculate and is performed under local anesthesia with a short recovery time. Tubal ligation involves surgically occluding, cutting, or sealing the fallopian tubes to prevent eggs from reaching the uterus, and typically requires general or regional anesthesia and a brief hospital stay. Both procedures are intended to provide definitive, long-term prevention of pregnancy. These methods are effective and eliminate the need for ongoing contraceptive use, making them a suitable choice for people certain they do not want future biological children. Important drawbacks are that they are generally considered irreversible. Reversal procedures are complex and not reliably successful, and they do not protect against sexually transmitted infections. Informed consent and thorough counseling about permanence, alternatives, timing, potential surgical risks, and the emotional and reproductive implications are essential before proceeding. A vasectomy is a minor surgical procedure in which the vas deferens are cut, tied, or sealed to prevent sperm from entering the ejaculate, providing permanent contraception for men. The procedure is usually done under local anesthesia in an outpatient setting and requires follow-up semen analysis to confirm azoospermia before relying on it for contraception. Advantages include very high effectiveness, low ongoing cost, minimal effect on sexual function, and no day-to-day user action. Disadvantages are that it is intended to be permanent, so reversal is difficult and not always successful. It offers no protection against sexually transmitted infections, and there are small short-term surgical risks, such as bleeding, infection, or post-vasectomy pain. Typical failure after the recommended follow-up confirming azoospermia is under 1%, though rare late recanalization and failures have been reported. Tubal ligation is a surgical procedure that permanently prevents pregnancy by occluding, cutting, clipping, or sealing the fallopian tubes so that eggs cannot meet sperm. It is usually performed under general or regional anesthesia either at the time of a cesarean delivery, soon after childbirth, or as an interval procedure and requires a brief recovery period. Its advantages are durable, highly effective contraception without the need for ongoing user action and rapid return to usual activities after recovery. Drawbacks include the risks of surgery and anesthesia, the general permanence of the method with reversal procedures that are complex and not always successful, and the absence of protection against sexually transmitted infections. There is a small residual risk of pregnancy after the procedure, and if pregnancy does occur, it has a higher chance of being ectopic. So counseling should cover informed consent, alternatives, and what to do if pregnancy is suspected. Natural and behavioral methods include fertility awareness approaches such as calendar methods, basal body temperature, cervical mucus tracking, and symptothermal combinations, the withdrawal method, and the lactational amenorrhea method. They are hormone-free and inexpensive, rely on monitoring or partner behavior to avoid intercourse during fertile periods or to prevent semen entering the reproductive tract, and can empower users who prefer non-medical options. Fertility awareness methods use observation and recording of menstrual cycle indicators, calendar tracking, basal body temperature, and cervical mucus to identify the fertile window so couples avoid unprotected intercourse during that time. The symptothermal approach combines 2 or more signs to improve accuracy. Advantages are that fertility awareness methods are hormone-free, inexpensive, promote body awareness, and can empower users who wish to avoid medical interventions. disadvantages are the need for daily attention, careful record-keeping, and training to interpret signs correctly. Effectiveness falls sharply with inconsistent use, irregular cycles, or intermittent breastfeeding. These methods provide no STI protection and are less suitable for people with unpredictable cycles. Typical use pregnancy rates vary widely by method and user training. Broad estimates place typical use failure around 12 to 24% per year, while highly motivated, well-trained users of symptothermal methods can achieve much lower failure rates, closer to 1 to 5% per year. Keep a menstrual calendar for at least 6 cycles, recording the first day of full menstrual bleeding as day 1 for each cycle. From those entries, identify your shortest and longest cycle lengths. The shortest and longest counts from day 1 to the day before the next period. Then calculate your fertile window using the rhythm formula. The first fertile day is your shortest cycle length minus 18, and the last fertile day is your longest cycle length minus 11. Then, mark those fertile days on each cycle and avoid unprotected vaginal sex during that window. Finally, update your records and recalculate the shortest and longest cycle after each new month's data to refine future estimates. Let's use the following data to calculate the fertile window. If your shortest cycle is 26 days and your longest is 30 days, using the rhythm formula to find your fertile window, you subtract 18 from the shortest cycle to get the first fertile day. 26 minus 18 equals day 8, and subtract 11 from the longest cycle to get the last fertile day. 30 minus 11 equals day 19. So the estimated fertile window for each cycle would be days 8 through 19. The cervical mucus method relies on daily observation of vaginal discharge to identify the fertile window. As estrogen rises before ovulation, mucus becomes clearer, stretchier, and more slippery, similar to egg white in quality, signaling peak fertility. During this period, you should avoid unprotected sex from the first day you notice any fertile type mucus until 4 days after the last day of that mucus to reduce pregnancy risk. Record findings each day. Check mucus by wiping or observing at the vulva, not just from toilet paper, and combine with cycle charting or other signs for greater reliability. Measure your basal body temperature every morning immediately upon waking, before getting out of bed, using a digital basal thermometer at the same time each day after at least 3 to 5 hours of uninterrupted sleep, and record the value on a chart or app. Over several cycles, you will see a pattern in which ovulation is followed by a sustained temperature rise of about 0.3 to 0.5 degrees Celsius, indicating that the fertile period has ended. So avoid unprotected intercourse from the start of the fertile phase, at least 3 days before the temperature rise, and until at least 3 days after the sustained rise. And be aware that illness, alcohol, inconsistent sleep, or shift work can alter readings and reduce reliability. So combining basal body temperature with mucus tracking or other fertility signs improves accuracy. A symptothermal method combines daily tracking of basal body temperature, cervical mucus, and other fertile signs, such as cervical position and ovulation pain, to identify the start and end of the fertile window, using the temperature rise to confirm ovulation after mucus shows peak fertility, and then avoiding unprotected intercourse from the first day of fertile type mucus until at least 3 days after a sustained post-ovulatory temperature rise. It increases reliability compared with single-sign methods, requires consistent daily measurements and record-keeping, benefits from training or an app for pattern interpretation, does not protect against STIs, and may be less reliable with irregular cycles, illness, or disrupted sleep. The withdrawal method involves the penis being pulled out of the vagina before ejaculation, so semen does not enter the reproductive tract. It requires good timing, strong self-control, and consistent partner cooperation. Advantages are that it has no direct cost, is always available, and requires no devices or hormones. Disadvantages are high dependence on user skill, with significant risk of error, no protection against sexually transmitted infections, and the possibility that pre-ejaculatory fluid may contain sperm. With typical use, the pregnancy rate is about 20% per year. The lactational amenorrhea method provides temporary contraception by suppressing ovulation through the neuroendocrine effects of frequent, near-exclusive breastfeeding during the first 6 months postpartum, while the mother remains amenorrheic. It requires on-demand breastfeeding day and night with short intervals between feeds and no regular supplementation. When the three strict criteria are met: exclusive or nearly exclusive breastfeeding, infant younger than 6 months, and absence of menses, lactational amenorrhea method can be highly effective, with failure rates comparable to modern methods in that interval. But its effectiveness falls rapidly if breastfeeding frequency or exclusivity decreases, if menses resumes, or after 6 months, and it offers no protection against sexually transmitted infections. Evidence-based guidance that help clinicians determine which contraceptive methods are safe for people with specific medical conditions, characteristics, or life stages. The World Health Organization published a global MEC framework used to classify method-condition combinations by safety and to support safe choice and access worldwide. Before recommending a contraceptive method, assess each patient's individual risk factors and life circumstances, including medical history, current medications, reproductive plans, and ability to adhere to the chosen method. Use medical eligibility tables to match contraceptive options to specific conditions, noting whether a method is considered safe, requires caution, or is contraindicated for that patient. Pay particular attention to postpartum status and breastfeeding, cardiovascular risk, including thrombosis and cigarette smoking, liver disease, and age-related concerns when selecting a method. When contraindications or uncertainty exist, safer alternatives such as progestin-only methods instead of combined estrogen and progestin options when estrogen is unsuitable. Document the counseling provided, the clinical rationale for the chosen method, and a clear plan for follow-up and method switching if circumstances change. Counseling should begin with a clear assessment of the patient's reproductive goals, timeline for future pregnancy, medical history, current medications, and lifestyle factors that affect method suitability and adherence. Present contraceptive options by effectiveness, reversibility, side effects, and impact on bleeding and sexual function, emphasizing the methods that best match the patient's goals and clinical profile. Explain how each option works, common and serious adverse effects, and any important initiation or continuation considerations, such as timing after delivery or interactions with other drugs. Discuss non-contraceptive benefits and limitations, including protection against sexually transmitted infections and whether use requires daily or periodic action. Explore the patient's preferences, concerns, and ability to adhere, then recommend 1 or 2 options while offering contingency plans. Document the counseling content, chosen method, informed consent, and a follow-up plan that includes how to manage side effects and when to seek urgent care. Recognize that family planning care must respect patient autonomy and informed consent, ensuring that individuals receive unbiased information and sufficient time to choose without coercion. Uphold confidentiality and privacy throughout counseling and provision. Be attentive to cultural and religious beliefs that influence preferences and acceptability of methods. Engage respectfully with patients' values and offer culturally sensitive alternatives while avoiding judgment. Understand legal frameworks and institutional policies that affect access, including age of consent, parental or spousal consent requirements where applicable, and national laws governing reproductive health services and funding, and ensure practice complies with those regulations. Address equity and access by identifying and mitigating barriers for marginalized populations, including cost, geographic availability, language, disability, and discrimination. Finally, balance public health goals with individual rights by promoting voluntary, evidence-based services, documenting informed consent, and referring patients for additional support or legal counsel when ethical or legal conflicts arise. Let's end this lecture with some key points. Family planning methods fall into clear categories: barrier methods, hormonal methods, intrauterine devices, permanent methods, and natural behavioral methods. Sterilization and long-acting reversible contraceptives are the most effective options with TIP under 1%, while short-acting hormonal methods require consistent adherence and therefore have higher typical failure rates. Condoms provide STI protection and should be emphasized when infection risk exists. Other barrier methods are more user-dependent and less reliable for pregnancy prevention. And behavioral methods carry comparatively high typical failure rates, except when lactational amenorrhea methods' strict criteria are fully met. Clinical care must start with assessing a patient's reproductive goals, medical contraindications, breastfeeding status, and sexually transmitted infection risk. Then use shared decision-making to discuss efficacy, side effects, reversibility, and patient preferences to select the most appropriate method. Practical follow-up includes confirming azoospermia after vasectomy, counseling about expected bleeding or hormonal effects with intrauterine devices and subdermal implants, and arranging review for concerning symptoms, and offering sexually transmitted infection testing and condoms when indicated.